Assalamu alaikum wa rahmatullahi wa barakatuh. Now we'll talk about the fourth parts of pediatric emergency lectures. We'll talk about diabetic ketoacidosis or DKA. Diabetes mellitus 1 type 1 results from the autoimmune destruction of insulin-producing beta cells, islets of the pancreas. In addition to the presence of diabetes susceptibility genes, an unknown environmental insult presumably triggers the autoimmune process. A variety of studies have produced conflicting data regarding a host of environmental factors. These include cow's milk feeding before age of 2 years, viral infections like Coxsackie virus, cytomegalovirus, mumps, and rubella, and possibly vitamin D deficiency. In the United States, the annual incidence is approximately 20 in 100,000. The annual incidence in children ranges from a high of 40 in 100,000 among Scandinavian populations to less than 1 in 100,000 in China. The annual incidence of diabetes mellitus type 1 is increasing steadily, but with significant geographic differences. DKA, an endocrinologic condition caused by an absolute or relative lack of insulin. It is characterized by hyperglycemia above 300 mg per deciliter, dehydration, and metabolic acidosis. DKA is more often seen as the initial presentation of diabetes in young children. In young patients, DKA accounts for 70% of diabetes-related deaths. Reversal of DKA is associated with inherent risk that include hypoglycemia, hypokalemia, and cerebral edema. Any protocol must be used with caution and close monitoring of the patient. Now we'll talk about DKA treatment protocol. In the first hour, 10 to 20 ml per kg intravenous bolus of 0.9% normal saline or ringer lactate plus insulin drip at 0.05 to 0.1 unit per kg per hour. Then 0.45, that is 1/2 normal saline, 85 ml per kg, plus maintenance minus bolus over 23 hours, plus continuous insulin drip. DKA treatment protocol include a quick volume expansion. This may be repeated. Nothing per mouth, monitor of input-output, neurologic status, use of flow sheet, have mannitol at bedside, 1 gram per kg IV, push for cerebral edema. Serum glucose concentration should decrease at a rate no faster than 100 mg per deciliter per hour. From the second hour until DKA resolution, 20 milliequivalent per liter of potassium phosphate and 20 milliequivalent per liter of potassium acetate plus 5% glucose if blood sugar is below 250 mg per deciliter, that is 14 millimole per liter. If potassium less than 3 milliequivalent per liter, give 0.5 to 1 milliequivalent per kg as oral potassium solution, or increase IV potassium to 80 milliequivalent per liter. At variable time, oral intake with subcutaneous insulin provided no emesis, CO2 more than or equal 60 milliequivalent per liter, and normal electrolytes. Correction of metabolic acidosis by sodium bicarb is only indicated when acidosis is severe, that is pH below 7.5 and SCO3 below 10 milliequivalent per liter, A single dose of sodium bicarb, 5%, 2 ml per kg IV over 10 minutes is sufficient, as complete correction will occur with IV fluid therapy and insulin therapy. Continuous observation of level of consciousness and state of hydration and vital signs. Laboratory investigations should be made every 2 to 4 hours for blood sugar, serum electrolytes, sodium, potassium, acid-base balance by blood gas analysis, pH, PaCO2, SCO3, urine analysis for sugar and acetone. When infection seems to be precipitating factor, blood and urine culture should be made. Now we'll talk about poisoning. Another important emergency. Poisoning in children is a common clinical problem and common cause of hospital admission for observation and treatment. Poisoning can occur with drugs, cleaning agent, insecticides, paints, petroleum products, plants, and inhalation of toxic gases as carbon monoxide or other toxic gases or fumes. Now we'll talk about hydrocarbon poisoning. Hydrocarbon include a wide variety of chemical substances found in commercial products. The most important toxic effect of hydrocarbons is aspiration pneumonitis. Aspiration usually occurs at the time of ingestion, when coughing and gagging are common, but can be secondary to vomiting that commonly occur after ingestion. Hydrocarbons can be absorbed after ingestion, inhalation, or dermal contact. Most hydrocarbons have anesthetic properties and can cause transient CNS depression. Kerosene poisoning is the most common type. Aspiration is characterized by coughing, which usually is the first clinical finding. Chest radiograph may be normal for as long as 8 to 12 hours after aspiration. Respiratory symptoms may remain mild or may rapidly progress to respiratory failure. Fever occurs and may persist for as long as 10 days after aspiration. Accompanying leukocytosis may be misleading because in most cases of aspiration pneumonitis, no bacteria are present in the lungs. Treatment of kerosene poisoning. Emesis is contraindicated because of the risk of aspiration. Likewise, gastric lavage is contraindicated except under special circumstances because of the risk of vomiting and aspiration. Activated charcoal also is not useful because it does not bind to common hydrocarbons. If hydrocarbon-induced pneumonitis develops, respiratory treatment is supportive. Corticosteroids should be avoided because they are not effective and may be harmful. Prophylactic antibiotics should not be given because bacterial pneumonia occurs in only very small percentage of cases. It is indicated with re-emergence of fever or when fever continues for more than 3 days. Respiratory failure has been successfully treated with both standard ventilation and with ECMO, extracorporeal membrane oxygenation. Now we talk about organophosphate and carbamate poisoning. It is the most severe poisoning emergency in pediatrics. The most commonly used insecticides are either organophosphate or carbamates. Both of these classes are inhibitors of cholinesterase enzymes. Nerve agents used in warfare are organophosphate. Most pediatrics poisonings occur as the result of accidental exposure to insecticides in and around the home or farm. Clinical manifestation of organophosphate and carbamate toxicity related to the accumulation of acetylcholine at the peripheral nicotinic and muscarinic synapses and in the central nervous system. Muscarinic signs and symptoms include diaphoresis, emesis, urinary and fecal incontinence, tearing, drooling, bronchoria, and bronchospasm, meiosis, hypotension, and bradycardia. Nicotinic signs and symptoms include muscle weakness, fasciculation, tremors, hyperventilation, hypertension, tachycardia, and dysrhythmia. CNS effect include malaise, confusion, delirium, seizure, and coma. Symptoms caused by carbamate toxicity are usually less severe than those seen with organophosphate. RBC, cholesterol level, is decreased. Treatment, basic decontamination should be done on exposed person. Activated charcoal can be used for gastric decontamination. Basic supportive care should be provided, including fluid and electrolyte replacement and intubation with artificial ventilation if necessary. Two antidotes are useful in treatment, atropine and pralidoxime. Atropine, which blocks the acetylcholine receptors, is useful for both organophosphate and carbamate. It is most effective at reversing the muscarinic and CNS effects. Often a large dose of atropine must be administered by continuous infusion, 0.05 mg per kg IV, repeated every 5 to 10 minutes as needed. Dilute in 1 to 2 ml of normal saline for endotracheal instillation. Pralidoxime chemically breaks the bond between the organophosphate and the enzyme, liberating the enzyme and degrading the organophosphates. 25 to 50 mg per kg over 5 to 10 minutes, maximum 200 mg per minute, can be repeated after 1 to 2 hours, then every 10 to 12 hours as needed. Pralidoxime is only effective if used before the bond ages and becomes permanent. Aging occurs over the 2 to 3 days after exposure. Pralidoxime is not necessary for carbamate poisoning because the bond between the insecticide and the enzyme degrades spontaneously. Without treatment, symptoms of organophosphate poisoning may persist for weeks, requiring continuous supportive care. Even with treatment, neurologic symptoms may occur and may persist. Thank you very much. And this is the end of the lecture of pediatric emergency.